It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Happy New Year. Hope you guys are all doing well. I started off the year with an ultrasound course last weekend in New York. It went great. And I had a request 2 weeks ago from a dentist who is looking to understand TMJ ultrasound. He does a lot of TMJ work. I must admit, I don't do a lot of TMJ work, but I have some experience with the TMJ as well as the cranial nerve blocks. So he asked me to go over the ultrasound for that. So I am developing a program for ultrasound-guided cranial nerve and oromaxillary facial pain, and that's going to be released soon. I'm doing a private session with him this weekend, and I'm putting on the finishing touches of the presentation, and it will be available in the virtual pain fellowship as well as possibly a separate webinar or a separate in-person training course. I'm fine-tuning it every day. That being said, one of the resources I used for this course was an article by Andrea Trescott, who, if you don't know, she's very well known. She wrote a lot about peripheral nerves, peripheral neuromodulation. In fact, I authored a chapter in one of her books, actually 2 chapters on the cluneal nerves, and she wrote a really nice article here entitled Ultrasound for Evaluation and Treatment of Headaches. And basically, in her abstract, she discusses that headaches are a common complaint affecting millions of people, obviously. The pains have been attributed to intracranial processes such as dilated blood vessels, trigeminal ganglion, and therefore amenable to medication therapies. However, many of these headaches, including migraines, may be caused by extracranial conditions that can be diagnosed and treated quickly with interventional pain techniques using pattern recognition. They identify many headaches and then use ultrasound to diagnose, treat the underlying condition. And they basically target the supraorbital Auriculotemproal Neuralgia and greater occipital neuralgia for their role in headache management. I could not agree with this more, because how many people have come to my office or your office saying they have migraines, and the neurologist throws all the meds at them, but then you do some sort of occipital or supraorbital nerve block and they respond. I see it all the time. I believe most headaches are multifactorial, or maybe there's one initiating event, but it can be treated by multiple routes, and you need to look at the pattern of pain. If it's above the eye, it may respond. In fact, I have a gentleman right now who he's a contractor, and his boss is having him work on some like $30 million project and told him he needs to work, and they're desperate to get him care. So what he opted for was what I thought was probably the best way to give him quick pain relief, which was basically his pain was in the occiput, radiating behind the eye and supraorbital region. So after responding to the greater occipital nerve temporarily, we blocked that. I did a cryoablation of the nerve, and he wound up doing great with that. In fact, as soon as I did the ablation, the retroorbital pain disappeared, and he came back saying he still had residual pain in the lesser occipital and supraorbital distribution. I did each of those nerve blocks separately, and the pain was relieved for about 2-3 months, just as the cryotherapy was starting to wear off. The cryoablation, by the way, works by disrupting the myelin cells. So the myelin grew back over the course of the 3 months, and the pain started again, and he wanted to stay ahead of it. So even when he was not in the 10 out of 10 pain he originally presented with, his pain was more like a 5, he wanted to have the ablation again. And this time he opted for the greater and lesser occipital nerve ablation. And the funny thing is, when I ablated the first time, he felt some pain at the site, and he did not get that greater occipital distribution sensation. So I repeated it, and he received that sensation immediately. And the lesser as well, which on him, the lesser occipital nerve is beautiful and very easy to find. In fact, he is the patient in that video that I posted on YouTube, on the Pain Exam YouTube channel. It's probably on the blog post as well. And it's in my ultrasound course where I'm doing a lesser occipital nerve block scanning upwards from the superficial cervical plexus. So if you haven't seen it, check it out, and you'll see what I'm talking about. It's a pretty small nerve, but you can find it. And he did not need a repeat supraorbital nerve block. By doing the greater and lesser cryoablation of the occipital nerves, he responded quite well. I just saw him for follow-up this week, and he's doing great. So the neurologists are not always thinking about these things, and just like I'm not thinking of throwing triptans at people, I usually just refer them to the neurologist. So there's different ways to target headaches, and let's get started. So back to this article. One of the commonly followed classification schemes for headaches is the International Classification of Headache Disorders. I think like 8 years ago I did a podcast on this, and I'm sure the criteria was updated since then. Anyway, it focuses on categorizing and describing headache patterns. They describe the ones with the peripheral nerve contributions or distributions as other terminal branch neuralgias. And speaking of which, let's start with the supraorbital. We're going to work our way down. It has an incidence of about 4% of extracranial headaches, and it's localized above the eye on the forehead. It could be unilateral or bilateral. It presents as supraorbital, retroorbital, and forehead pain, and it can be sharp, throbbing, and there can be vision loss or changes, nausea, photophobia, and this can confuse diagnosis. Triptans have been known to temporarily relieve the pain by vasoconstricting the blood vessels traveling with the nerve, decreasing the entrapment. And there's pain that could radiate distally along the supraorbital nerve to the vertex of the skull. Now, just anecdotally, when I do this block, I got to tell you, it's like less than a milliliter of local anesthetic, a minute amount, a small amount of steroid, and I'm seeing weeks to months of relief, even sometimes like cures. So it's really, I think should be a first-line therapy before you put people on pills. That's my own personal opinion. I mean, you could try the Tylenol, ibuprofen first. And by the way, I'm not from, the neurology school of thought, so maybe they have their headache guidelines, which I'm sure I've read in the past and probably don't really refer to nerve blocks first. So take that as a grain of salt. I'm not reviewing the guidelines today, and to be honest, I don't even remember. But if somebody presents with a supraorbital neuralgia, I would give them an injection first because you could possibly just cure them right then and there, then prescribe long-term medication, which can have side effects or more side effects. So let's go and get into the anatomy of this nerve. The supraorbital nerve is one of the 5 peripheral branches of the ophthalmic division of the trigeminal nerve, cranial nerve V5, and it gives rise to 3 divisions: ophthalmic V1, maxillary V2, and mandibular V3. The V2 and V3 divisions branch downward. The V1 division branches superior immediately to the trigeminal ganglion until it enters the orbit posteriorly via the supraorbital fissure. It divides into 3, the lacrimal nerve, the nasociliary nerve, and the frontal nerve. The frontal nerve splits into the supraorbital nerve, which exits the orbit with the supraorbital artery via the supraorbital notch, and the supratrochlear nerve exits the supratrochlear artery via the supratrochlear groove or notch, and runs immediately into the small groove at the junction of the ocular ridge and the nares. And then the supraorbital nerve then branches into medial lateral branches over the forehead. So there are some nice pictures here, And the entrapment occurs at the supraorbital notch as the nerve leaves the orbit, passing through the supraorbital notch, the orbicularis oculi muscles, the glabellar muscles, and the corrugator muscles, and can be exacerbated by frowning, squinting. And this may be why migraines respond to the use of eyeglasses or Botox. Other things that can exacerbate this is tight-fitting goggles, anesthesia masks, which can compress the nerve. There can also be trauma to the head, which can also, or surgery that can cause the pain to develop from nerve entrapment. So can calcifications of the ligament, etc. So basically, the patient will have pain in the region above the eye, and there may be tenderness to palpation over the supraorbital foramen, and the paresthesias or pain can develop in that region, correlating with the nerve distribution. So under ultrasound, you can find the foramen, and sometimes you see the artery with it, and you could block the nerve and give relief. So moving on to the auriculotemporal neuralgia. Temporal headaches may be due to entrapment of the auriculotemporal nerve, a third division branch of the trigeminal nerve. The pain can be in the auricular area and the TMJ region. It's a common headache site. Just visualize all the headache patients rubbing or pressing their temples for relief. Shared with temporal migraine headaches, it may be misdiagnosed as an intracranial migraine, and it has other names such as Frey syndrome, auriculotemporal syndrome, Bale-Larger syndrome, Dupuy syndrome, Salvis-Sodori Paris syndrome, and gustatory sweating syndrome. I'm sorry, I couldn't keep a straight face. I never heard of half of these. But anyway, they state that entrapment of the auriculotemporal nerve is probably the most common of the trigeminal headaches. And they evaluated in a study by Calandra a specific area of the scalp that could be manually palpated to elicit a headache. 42.6% of these trigger points were found in the temporal region and 33.4% in the suboccipital region. However, auriculotemporal nerve entrapment is rarely diagnosed and represented in only 0.4% of the referrals to a tertiary headache outpatient clinic. There are two main presentations for irritation of this nerve, and the auriculotemporal neuralgia and the rare auriculotemporal syndrome, which both have overlapping presentations and multiple etiologies. The neuralgia presents as paroxysmal attacks of pain in the periauricular and temporal regions, as well as retroorbital region and teeth. The patient with auriculotemporal neuralgia pain due to entrapment will awaken at 3 to 4 a.m. with a headache in the auriculotemporal area that radiates to the temples and the retroorbital as well as the occipital regions. And the headache may be unilateral, bilateral, or may have associated ear, parotid, jaw pain, or numbness. The headache is throbbing in nature due to its proximity to the temporal artery, and it's often increased pain with talking, chewing, menses. The intensity of the pain is moderate to severe and can be constant at time. The pain may be triggered by trauma to the jaw as well as surgery, palpation over the periauricular area, chewing, and it can be associated with nausea, vomiting. The main characteristic accompanying nausea and vomiting meet the International Headache Society criteria for migraine, though there is no specific listing for auriculotemporal neuralgia. That's very interesting because I know these neurologists are not thinking about this stuff the way we are. I'm not saying that we're right and they're wrong, but sometimes we are. Anyway, the early morning headaches appear to be related to bruxism or nocturnal jaw clenching. And there can be a physical connection with the facial nerve. Look at the anatomy. There can be pain in the muscles of facial expression with auriculotemporal nerve entrapment. So, in terms of the syndrome, it's also known as Frey syndrome, and there's a constellation of symptoms including unilateral hyperhidrosis, flushing of the cheek and ear that occurs while eating or drinking, anything that stimulates the parotid gland to produce saliva. Pain is uncommon, but there is sensory changes in the auriculotemporal nerve distribution. There may be a concomitant trigeminal neuralgia known as Bale-Larger syndrome, Dupuy syndrome, and the Salvis-Sodori syndrome and gustatory sweating syndrome. They usually occur 2 to 12 to 13 months after surgery, open trauma, or infection of the parotid gland. Though it has also been described after dislocation of the mandibular condyle. The proposed cause is an improper regeneration of the sympathetic and parasympathetic nerves of the parotid gland, and the syndrome occurs in 5% of surgical patients, even with careful technique. The symptoms associated with Frey syndrome can range from mild to debilitating. This Frey syndrome, I have to be honest, I did not know much about, but the more I'm reading about this, I think it's quite testable for the boards. Reminds me of Eagle syndrome, something which I didn't really learn much about in fellowship until right before the boards came, because I never saw it in my clinic. And as an attending, I've probably only seen it 1 or 2 times. And if you don't know what Eagle syndrome is, it's glossopharyngeal neuralgia, which I'm not going to talk about. I did do a podcast on that in the past. Anyway, there's a great picture here where they have a patient with a scar over the parotid, and it's a patient suffering from Frey syndrome. So he gets facial flushing with eating. Anyway, the anatomy of the auriculotemporal nerve, it's a branch of the third division mandibular of the trigeminal nerve. The mandibular nerve exits the cranium through the foramen ovale and then immediately divides into the anterior-posterior division. There's sensation to the TMJ, the tragus, the external auditory meatus, the parotid, base of the auricle, and the skin on the temporal region being covered. The anterior division travels between the roof of the infratemporal fossa and the lateral pterygoid muscle and is composed of the anterior deep temporal nerve, the posterior deep temporal nerve, and the mesenteric nerves. The posterior division consists of the lingual nerve, inferior alveolar nerve, and the auriculotemporal nerve descending immediately to the lateral pterygoid muscle. Because the auriculotemporal nerve has a long, tortuous course, it is at risk for irritation and entrapment. The auriculotemporal nerve arises by 2 roots which travel on either side of the ascending middle meningeal artery and join together to form the short trunk. It leaves the foramen ovale, runs beneath the pterygoidus externus to the medial side of the neck and mandible. It then turns upward to the superficial temporal artery between the ear and condyle of the mandible. Hence, this is why the dentist who is doing the private course wants to know about this nerve so he can treat patients with TMJ. It covers the condyle of the mandible under the parotid. It leaves the gland, ascends over the zygomatic arch, traveling in front of the temporal mandibular joint, providing the primary innervation of the joint as it goes by to pierce the temporalis muscle. The nerve then divides into 5 small branches, including the nerve to the external auditory meatus, innervating the skin of the meatus, and the external tympanic membrane, the parotid branch nerve, the articular branches, which innervate the posterior part of the TMJ, and the superficial temporal nerve, which innervates the skin of the temporal region. The superficial temporal nerve communicates with the facial nerve, zygomatic nerve, which is a branch of the maxillary nerve, and zygomatic branches of the facial nerve. It's been associated with migraines, okay? So this is a really important nerve when you're treating TMJ or headaches. There's a lot more good information in this article by Dr. Trescott. I mean, this is a great text, and I highly recommend reading it. There's some contributions here I see from David Spinner, who is also well known in the world of pain and ultrasound-guided pain. And so the next nerve is the occipital nerve, which I'm not going to spend too much time on, and because I have so many other podcasts about this nerve and talk about it all the time. They go into the lesser, the greater, the third occipital nerve, and you could read about that on your own or just listen to my other podcasts about them and how to find those nerves. So I really think this was a very useful article. I'm taking some pearls for my presentation, and I hope to see you guys at the ultrasound courses. We have one coming up in Miami, and then I'll be running an ultrasound course at a West Virginia State Interventional Pain Physician Conference, the West Virginia SIP Conference in April. So if you can make it, it's the Appalachian Pain Society, basically, I guess, partnered with that. And everything's located on my website. Pain exam board review, go to painexam.com or just check out entrapment where everything is now transferred to. The whole board review for pain, physiatry, ultrasound, my regenerative medicine course, online ultrasound training, and more is all available there. So check it out. If you want the complete pain experience, check out the Virtual Pain Fellowship, which this headache and cranial nerve TMJ lecture will eventually be part of. So thanks for listening. I really appreciate you guys. If you're happy with the content, please give us a review on the podcast platform of your choice, or share the podcast with a friend. If you're not happy, let me know. Thank you, and have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.